Continuation. Wiskott-Aldrich syndrome, WAS. The severity of this X-linked disorder increases with age and usually results in fatal infection or lymphoid malignancy. Initially, T and B lymphocytes are present in normal numbers. WAS first manifests itself by defective response to bacterial polysaccharides and by lower than average IgM levels. Other responses and effector mechanisms are normal in the early stages of the syndrome. As the WAS sufferer ages, there are recurrent bacterial infections and a gradual loss of humoral and cellular responses. The syndrome includes thrombocytopenia, lowered platelet count. The existing platelets are smaller than usual and have a short half-life, which may lead to fatal bleeding. So, eczema, skin rashes in varying degrees of severity may also occur, usually beginning around 1 year of age. The defect in WAS has been mapped to a short arm of X chromosomes and involves a cytoskeleton glycoprotein present in lymphoid cells called cyeloporin. The WAS protein is required for assembly of actin filaments required for the formation of microvesicles. Then, interferon gamma receptor defect. An immunodeficiency that falls into a mixed cell category involves a defect in the receptor for interferon gamma, IFN gamma. This deficiency was found in patients suffering from infection with atypical mycobacteria, intercellular organisms related to bacteria that cause tuberculosis and leprosy. Most of those carrying this autosomal recessive trait are from families with a history of inbreeding. The susceptibility to infection with mycobacteria is selective in those who survive these infections are not unusually susceptible to other agents, including other intracellular bacteria. This immunodeficiency points to a specific role for IFN gamma and its receptor in protection from infection with mycobacteria. Detailed analysis of patients with increased mycobacterium infections implicated defects in IL-12 receptor as well as the IFN gamma receptor. Similar predisposition to mycobacterial infection results from defects in the NFKB2 mycobacterial pathway that include transcriptional activation of IFN gamma genes. A more complex defect sometimes involving tooth and skin pigment abnormalities along with mycobacterial infection is seen in patients with defects in the IKK protein subunits designated NEMO. Recall that IKK mediates the release of NF-kappa B from its inhibitor, allowing it to migrate to the nucleus where it activates immune response genes. Whereas SCID and the related combined immunodeficiencies affect T cells or all lymphoid cells, other primary immunodeficiencies affect B cell function and result in the reduction or absence of some or all classes of immunoglobulins. Although the underlying defects have been identified for some of these, several of the more common deficiencies, such as common variable immunodeficiency and selective IgA deficiency, appear to involve multiple genes and a continuum of phenotypes. Later, we're going to learn about X-linked A-gamma globulinemia. A B cell defect called X-linked A-gamma globulinemia or Bruton's hypogammaglobulinemia is characterized by extremely low IgG levels and by the absence of other immunoglobulin classes. Individuals with XCLA have no peripheral B cell and suffer from recurrent bacterial infections beginning at about 9 months of age. A palliative treatment for these conditions is periodic administration of immunoglobulin, but patients seldom survive past their teens. There is a defect in B cell signal transduction in this disorder due to a defect in a transduction molecule called Bruton's tyrosine kinase or BTK after the investigator who described this syndrome. B cells in the XLA patient remain in the pre-B stage with H chains rearranged but L chains in their germline configuration. Then X-linked hyper IgM syndrome, a peculiar immunoglobulin deficiency first thought to result from a B cell defect has recently been shown to result instead from a defect in a T cell surface molecule. So X-linked hyper IgM XHM syndrome is characterized by deficiency of IgG, IgA and IgE and elevated levels of IgM, sometimes as high as 10 mg per ml. Normal IgM concentration is 1.5 mg per ml. Although individuals with XHM have normal numbers of B cells expressing membrane-bound IgM or IgD, they appear to lack B cells expressing membrane-bound IgG, IgA or IgE. XHM syndrome is generally inherited as an X-linked recessive disorder, but some forms appear to be acquired and affect both men and women. So affected individuals have high counts of IgM secreting plasma cells in their peripheral blood and lymphoid tissue. In addition, XHM patients often have high levels of autoantibodies to neutrophils, platelets, and red blood cells. Children with XHM suffer recurrent infections, especially respiratory infections, and are more severe than expected for a deficiency characterized by low levels of immunoglobulins. The defect in XHM is in the gene encoding the CD40 ligand, which maps to X chromosome. Th cells from patients with XHM fail to express functional CD40L on their membrane. Since an interaction between CD40 on the B cell and CD40L in the Th cell is required for B cell activation, the absence of these co-stimulatory signal inhibits the B cell response to T cell dependent antigens. The B cell response to T-independent antigens, however, is unaffected by its defect, accounting for the production of IgM antibodies, as described later. So, class switching and formation of memory B cells both require contact with Th cells with a CD40 to CD40L interaction. The absence of this interaction in XHM results in the loss of class switching to IgG, IgA or IgE isotypes and in the failure to produce memory B cells. In addition, XHM individuals fail to produce defects in cell interactions are common in lymphoid immunodeficiency. XHM individuals fail to produce germinal centers during a humoral response, which highlights the role of the CD40 to CD40L interaction in the generation of germinal centers. Next is about common variable immunodeficiency or CVI. CVI is characterized by a profound decrease in numbers of antibody producing plasma cells, low levels of most immunoglobulin isotypes like hypogammaglobulinemia, and recurrent infections. The condition is usually manifested later in life than other deficiencies and is sometimes called late onset hypogammaglobulinemia or incorrectly acquired hypogammaglobulinemia. So, however, CVI has a genetic component and is considered a primary immunodeficiency, although the exact pattern of inheritance is not known. Because the manifestations are very similar to those of acquired immunogammaglobulinemia, there is some confusion between the two forms. Infections in CVI sufferers are most frequently bacterial and be controlled by administration of immunoglobulin. In CVI patients, B cells fail to mature into plasma cells. However, in vitro studies show that CVI B cells are capable of maturing in response to appropriate differentiation signals. The underlying defect in CVI is not known but must involve either an in vivo blockage of maturation of B cells to plasma cell stage or their inability to produce a secreted form of immunoglobulins. Then hyper IgE syndrome, Job syndrome. A primary immunodeficiency characterized by skin abscess, recurrent pneumonia, eczema, and elevated levels of IgE accompanies facial abnormalities and bone fragility. This multi-system disorder is autosomal dominant and has variable repressivity. The gene for hyper IgE syndrome or HIES maps to chromosome 4. HIES immunologic signs include recurrent infection and eosinophilia, excessive eosinophils in addition to elevated IgE levels.